we have Christopher Clark, who is a 22-year veteran of the information technology world, is a principal security engineer at Synopsys Incorporated. Did I pronounce that right?
That's correct.
Cool. Right.
Pretty good for the first time.
I do get some things right. Chris utilizes his extensive background and experience to help organizations effectively integrate meaningful security practice into their environment. So all the speakers have mentioned in one form or another how important cybersecurity is, and we're going to dive right in and hear more about it right now. Okay? Ladies and gentlemen, Chris. Christopher.
Well, thank you. First, thank you for having me today. I look forward to presenting some of this information. We are going to take a little bit deeper dive. I'm not going to get into the weeds of technology and information system needs, but we are going to talk about some of the critical factors that can impact security. Earlier, we talked about legislation, what's realistic from the legislator side of the House versus self-driven reform. And we're going to touch on some of those things during this presentation and give you a better insight as to where cybersecurity starts from an issue standpoint and how some of those issues can be remediated. So let's see here. Let's make sure this is actually working. All right. So as indicated, I've been in the IT industry for a while. I'm not going to read these points point for point because they were graciously already done for me. But I do want to point out a couple of things. There's a number of other things that I've done. I've performed as a CIO for a hospital system. I have acted as a project manager, IT director, and a number of other roles. But what's different and what's special about what I do is I think differently. And why do I say this? Why is this important? Well, I think differently because when we look at where technology is going and some of the things that we've done from a technological standpoint are really far-reaching, future-reaching. You know, we've seen a lot of the stuff that was science fiction previously come to fruition. And when we start talking about that science fiction, we kind of have to wrap our heads around what are the long-term implications? What are the implications of a technology? There was a really great point made earlier that indicated sometimes from a business perspective, the sharing of information is very beneficial. But from an individual standpoint, personal standpoint, that may not be as beneficial. So we have to kind of think about some of these things. But what's important and what I want to focus on today is when we talk about these new technologies that are coming in or enhancements to existing technologies, all of them are connected. We are seeing everything connected via a network. And this is definitely a great benefit, but we have to take into consideration our reliance on that technology. When we look at embedded devices, infusion pumps, and the different pieces and parts that make up the infrastructure, is it reasonable to assume that all of these electronic components at some point in time could become infection points or attack points? Sorry, I keep forgetting that these aren't connected up. So we start seeing a dynamic medical network. Medical devices are, as I said, they're going to be connected. They're constantly evolving. They're expanding from moment to moment. One of the challenges that we're going to talk about a little bit later is we have manufacturers that are releasing new product, yet we have bioengineers and IT support that is just now rolling out product that may be one generation or even two generations before the current products that are out there. So we have this delay, this lag as we see these new products that may address security issues, but we also have to look at the previous products. Some of you who are in hospital systems have probably seen products that have been in a hospital environment for 5+ years, sometimes even 10 years. What are the potential implications of those devices as we go through the evaluation process? And we have to track that change and understand what that change looks like. So what are some of those trends that we're seeing? Well, one of the challenges that we're seeing is ransomware. We've all heard about the Medstar incident and the impact, or what we believe to be the impact. There's going to be further impact that is not going to be visible to us. But this ransomware issue is something that's going to be out there for quite a while. And there's a number of reasons for this that we're going to delve into a little bit later, but keep that in mind. We also, as everybody remember, Anthem. Anthem was a very large breach. I don't have this particular slide up here, but there is discussion that the back-end impact of that is actually upwards of $18 billion over the long term. So we really have to take into consideration What are we bringing into our environments? What does the training look like for the soft component, the people within our infrastructure? And how do we manage that as an overall process? But I want to dial that back again, just one more step. Infusion pumps. We've all heard about the Hospira incident. We know the FDA has actually taken action on that. But Hospira is just one of many devices that we know have potential issues that are out in the marketplace that are very prevalent and we need to take into account. Now, when we talk about vulnerabilities, we talk about issues, we talk about cybersecurity, what are we really talking about? Well, there's a people component to it, the soft component. But the reality is when we look at these devices, there's something that is applicable to all of them, and that's software. When we look at software, that is what's driving all of our infrastructure from a healthcare perspective and the underlying components that support healthcare. So we've talked about cloud, we've talked about service providers, we talked about all these other components that are really part of the puzzle. So when we talked about the infusion pump, oh, sorry, I forgot to move up a slide here. The challenges that are being faced by healthcare providers and manufacturers is that we have a group out there, which we typically call hackers, maybe black hats, maybe bad people, but there's also a subgroup of those individuals called researchers. And the researchers are the ones that are out there discovering and finding the information that hackers are already utilizing or being preemptive and finding information that hackers are utilizing and putting up barriers. So is anybody familiar with the company called TrapX? Anybody? Well, they're the company that discovered MedJack. And you may have heard about MedJack. MedJack is a framework for launching attacks against medical devices. So when I talk about a framework for launching attacks against medical devices, the first thing that comes to mind, especially if you're on the IT side of the house, is if they have a framework, that means there was some real work put behind this to develop some infrastructure to support these attacks. What does that look like? What are the type of people that are doing that? And the type of people that are doing that have a number of different reasons for performing their actions, but that's really irrelevant in this situation because we have to, as healthcare providers, address the issue and support the issue. Now, it's just not all gloom and doom here. I don't want to paint the picture that there is no possible fix for all this. That is not the case. There's a lot of options. In fact, some of the technology that we're talking about has some very interesting implications. Some of you may have heard about an ER patient that went in, and the doctor actually utilized the information from his Fitbit to help diagnose the problem the patient was having. This is a great move forward. This is something that's definitely of interest, and we want to be able to support this type of interactivity between home-provided data as well as data that's collected and generated in the healthcare space. But we do have to call into question how much trust can we place into this data that's being brought into us. Now, most everybody in here is going to be familiar with radiology services. One of those components is DICOM. If I go to a provider and I get an X-ray or a CT or an MRI, I can request a DVD or some type of physical source that has that information. What if I were to go home and change that information and then go to another facility and say, this is what I found from this other location, here's the data they presented to me, oh, by the way, at this facility I was John Doe, at this facility I'm Steve Doe. What are the potential impacts and challenges we're going to face in those situations? We haven't seen that, or we have seen that already in certain situations, maybe not as general as that, but that is a growing problem. The FBI has warned that pacemakers, defibrillators, monitors, and a number of other devices are at risk, especially if they have wireless connections. Also, healthcare data on the black market is far more valuable than financial data. Anybody, how much do you think a credit card, a stolen credit card, goes for these days on the black market? 10 cents. Even lower now. It's usually about 7.5 cents to 8 cents. It also depends on the provenance of the card. Medical records. Any ideas? $50 and up. If there is a record that actually has very specific maladies, such as cancer, those can go upwards of $200 to $250. So the more targeted they are, the more information that's available for that record, the more valuable it is. Unfortunately, when we look at the devices that are in a hospital system, they are surprisingly easy to cause issues, or to crash, cause some type of malformed event. I would even venture to say, those of you who are in a hospital system, when you talk to your biomed team and we talk about a device that's delivering patient care, one of the steps in managing that device is to reboot that device on a regular basis. Shut it down every night and restart it. Why is that? In most cases, that type of scenario is generated because we've had some type of event where the device has locked up or behaved in an erratic manner that is not normal, was not reported to the manufacturer of the FDA, but the solution was, let's fix it by restarting it. Now, I'm planting the seed because we're going to talk a little bit later about what is the cyclical process that we really need to be going through. When we look at vulnerabilities and we look at issues, very often we have no idea what the originating point is from a researcher standpoint. The black hat that was looking for this is going to find this information or will know this information. But it's never conveyed back to the manufacturer for remediation, and I shouldn't say never, in most cases. Does anybody know this good-looking guy here?
Billy Rios.
That's Billy Rios. Billy's a great guy. I know Billy very well. And what Billy shared with us was some very interesting information, some emails. And what's interesting about this is, if you can read those emails, those are people soliciting him, sorry, I keep forgetting this mic is over here, soliciting him for vulnerabilities. Now, for those of you who don't know who Billy Rios, he's a very well-known researcher. He does a lot of work. He's responsible for Hospira as well as many other vulnerability discoveries and disclosures. And he's very, very good at what he does. And what Billy points out, and what I agree with, because we both kind of think a little bit differently, is when we look at, or we take the perspective of most people, we see a vehicle. I'm not going to pick on an infusion pump here, but we see a vehicle and it's a unit. When I have a hospital administrator, he's looking at the components of a hospital that make that hospital run. If I'm an attacker, though, if I'm a black hat, I'm going to take that vehicle and I'm going to look at all the constituent components. And I'm going to see of each of those components, what can I leverage to perform what I want to do? I'm not going to look at prescribed methods. I'm not going to look at what the security posture of the hospital is. I'm going to go and see what is the path of least resistance to get into this infrastructure and do something. Now, I also want to point out something that's really important here. When we talk about attackers, typically we're looking for the path of least resistance. But in most cases, I don't know over the internet or over some other network if I'm actually trying to penetrate a hospital, a nuclear facility, a car dealership, a private practice, or anything else. What I am looking for is something that's of interest. So let's say maybe I do actually gain access to a private practice that also has a VPN access back to an upstream provider. That's a gold mine for me. And when I start looking at each of the parts that make up the puzzle, then you start to see, okay, I can dig in much deeper and find something that's interesting. So why do I bring this up? Well, I bring this up because everything we've talked about is software. And then historically, when we had a product in the early 80s, we had a piece of software. It was self-contained. It ran on one PC, and that's everything that it did. It didn't have any additional functionality. Well, then we bring in the internet. And we start to see that, okay, not only do we have to provide connectivity for internet access, we also have to make sure that the software they're developing that was originally had good quality, performed everything that it needed to do, now has security, because we're driving into an environment that's much less robust. The security measures that I need to implement are upon me. I don't always have the benefit of having whatever my underlying infrastructure of providing the security that I need. And then on top of that, now that we get to more modern environments, we have safety and privacy. So we have the trifecta: quality, security, safety, and privacy. Now, all those are not always beneficial to each other. If I want safety and privacy, my security has to be better, my quality may drop. And that quality isn't necessarily specific to the application crashes, but a very good example was user interface earlier. My user interface can be impacted by any one of the three items that we've talked about up to this point. And that is a critical component, especially when we look at manufacturing of medical devices, but we'll get to that a little bit later. But ultimately, what I want to point out here is as we've added these components, quality, security, and safety, we've also driven up the financial liability. Now, in this particular image here, I have the vehicle from Chris Valasek that they hacked. Everybody probably saw that on 60 Minutes. But our point to that is this. Not only are we realizing this as an industry, insurers are realizing this. Now, this particular example is out of the UK. They had some very interesting situations that occurred. I won't delve into the details, but as we can see here, NHA Trust was fined $325,000 for data breach. There's a number of situations that led up to this, but ultimately it was the theft of a hard drive. Now, that theft of a hard drive, in many practices or hospital systems that we look at today, we're going to have something like BitLocker or some other type of technology that's going to require some type of secure infrastructure to minimize the impact to the device. Or the
Being attacked.
Oh, no. What's going on?
I'll take care of it.
Okay.
Just click end meeting and you'll be fine.
Oh, that was from that previous meeting? I was like, oh, man, I'm getting cut off already. That's not good.
Attack on you.
Okay, 325 million pounds from the NHS Trust. As I said, it was a theft of a hard drive, theft of an individual component. Now, should that data have been able to have been extracted from that hard drive? Not likely. If it was in the U.S. and we had hospitals following best practices, we would have had BitLocker. That data would have been encrypted and wouldn't have been able to have been extracted. Guess what? BitLocker is not perfect. If I have the laptop and the device, there are a number of side channel attacks that would allow me to extract that information and get the keys and go through and extract that data. So while I'm talking about the technical aspect, what I really want to point out here is insurers are starting to look at this. There are a number of other landmark cases where hospitals have lost due to not following best practices. And what are those best practices? We're going to talk about some of those a little bit later on, but we're talking about NIST 800 type documents, NIST Cybersecurity Framework, and a number of other sources that are out there. Do we move forward this time? Okay, so what are some of these strategies? This isn't a technical audience, so I'm not going to go in depth into the types of strategies that are out there, but I will talk about a couple or three that are probably of interest, or you might have heard about. The first one is defense in depth, and that's probably a very popular buzzword right now. And what does that really mean? Well, for those of you who are in the IT space, I'm going to outline an idea of it. It's very, very or high level, so don't pick on me for that. But basically, I have different domains within my network, and that domain could be anything. It could be infusion pumps. It could be administrative desktops. It could be any number of areas that I have applied some type of security measure for that respective area. The implication to that is now that I've applied those security policies to those domains, I have a high administrative overhead from an IT perspective. I have to maintain that over time. And what does that cycle look like? It becomes very expensive. I may have to have additional support personnel to address that issue, but it becomes very difficult to manage over time, especially in extremely large organizations. Now, another type of security that you may have heard of is layered defense, and this one's a little bit older. And another term that you may hear for that is perimeter defense. So I have some type of boundary condition, which is that enterprise zone on the right side of the top salmon colored one. And then I have a somewhat trusted, not completely trusted zone where I have other resources that can reach both internally and externally. And then I have my internal infrastructure. As I said, this is a little bit of an older type of technology or methodology. But it did work for the time. And then for those of you who really enjoy punishment, there's a TSA 20 layers of security that I'm not even going to talk about because it's just brutal. But if you really want something to put you to sleep and hurt you, take a look at that. So why do I talk about these particular infrastructures? Well, remember, as an attacker, all of us, most of us in this room look at a vehicle, but as an attacker, I look at all these individual pieces and parts. And as I dig a little bit deeper, I start to look at all the different pain points that I can inflict upon a facility or organization or a manufacturer and gain entry to that. So, as an attacker, what if I was to walk into a hospital, go visit Uncle Joe, even though it's not my Uncle Joe, and I just walk in there, I say hello, and how's it going? And as I'm walking out the door, I plug a little device that's no bigger than a pack of gum into a network port, and it has a throughput, so the infusion pump that's plugged into it never disconnects. And now I have a listening point in that hospital. From an IT perspective, most people are going to say, well, that should be pretty easy to discover. But I can be pretty sneaky and make that device very, very hard to discover while it's gathering information. Maybe it has a Wi-Fi point. Maybe it has a cellular connection that it's actually throwing data out of the network that's now unmanaged. There's a number of other scenarios we could talk about, another number of other ideas, but I will throw out one story. Some of you may have heard. Physician came into a patient room. His phone was running low on power, and he decided he was going to plug it into one of the devices that was supporting the patient. Seems reasonable. There's a USB port right there. Why not? I just want to charge for a few minutes. He plugs it in. That device was never tested for that. That capability was never tested for that particular device. What happened? Rebooted the device. Crashed it and rebooted it. Unfortunately, what was that device? It was a ventilator. It was helping the patient breathe. Patient was okay, but we still needed to create, there was a record created, reported to the FDA, and there was some research done on that. But think about those kinds of scenarios. There's a lot of situations where things occur or things that are done where they are meant with the best of intentions, but the outcome is very, very different. So when I touch on that and I talk about that, there's a couple of pain points that we really need to understand. We were talking about all this technology, all this change, which is great. But what is that doing? That's putting a lot of pressure on clinical engineering, biomedical teams, and IT professionals, IT support. Some of the stories that I've presented to you may never make it to an IT individual or a biomed person, or maybe they're reported to IT, but it never makes it over to biomed. You have to look at what is that entire process for reviewing security and how information is passed back and forth within individual groups within a healthcare delivery system. It can be very challenging. In some cases, some people would feel that's almost impossible just because of the dichotomy between IT and biomed, but we really have to break down those walls and figure out how those groups can work together. And we have seen a number of large institutions, Mayo Clinic being one of them, where they've taken that and looked at what those processes are and how they address those. And I mentioned Mayo Clinic. All of you are more than welcome to reach out to Mayo Clinic. They're a trusted partner of ours. We work with them on a regular basis, and they're happy to share their experiences with you. So please leverage that information. And we're going to talk about procurement language a little bit later. Mayo is also very happy to share their procurement language that we're going to talk about here in a little bit. So it seems like I've painted a pretty terrible picture. There's really not a simple solution, and I would agree with that. There's a lot of challenges out there. But one thing that I always tell friends of mine or people who are trying to, this is an impossible thing. How do we do this? How do you eat an elephant? One bite at a time. So take one component of that, tear that apart, break it down, and then start working from there, because there are solutions and there are things that work. Oops. So, as I've indicated, and I think we're all in agreement, we live in a connected world. There is not a single component of the healthcare delivery system that does not have some component. We've talked about some practices that prefer not to move forward with EHR, high-tech, HIPAA, not necessarily HIPAA, but high-tech. They're going to be a small percentage. We have to move forward. We have to address these issues. This picture is very basic, and I keep it very basic intentionally. When we look at products that are coming into all the different environments I just presented, hospital, clinics, and other locations, radiology centers, typically when we're purchasing something, we follow these steps. We perform some type of evaluation, we procure the device, then we test the device to make sure it's really going to work our environment, then we train, and then we actually install it and roll it out. Is that really the best process to follow? Unfortunately, no. But as I said, I distill this down to some very basics, and almost every organization that we've ever talked to, except for two, basically fall into these categories. So why is this important? I'm going to frame this as what I call foundational security. And foundational security focuses on two things: the evaluation process and the procurement process. Why is that? When we look at medical devices, actually I shouldn't even focus on just medical. This is true of any device. When we look at any device that's really out on the marketplace today, most of the code that makes up that component, and remember we said vulnerabilities in cybersecurity really start at software, is open source. There's a lot of numbers out there. There's a lot of different statistics. The number we stick to is the 80-20 rule. And if we look at a device and we break down its components, about 80% of that is open source software or third-party software that's been purchased to make that device function. And there's a very small percentage of actually custom-written software to make that device function as is intended for its intended use. So why is that important? Well, let's identify some opportunities here. When we look at these devices, and in this case, we're looking at, which one was this one? This was central monitoring. When we took the software that actually runs this application, this product, this solution, and we broke it down, we find that there were 1,683 known vulnerabilities for this one particular platform. 378 of those vulnerabilities were in one module, a Java module. Now, I said something that's kind of important there. When we hear something in the news, we hear about 0 days. We hear about these events that are, oh my gosh, why did that happen? Why didn't we know about that? I wouldn't categorize that as a black swan event, but we're leading to that. What I'm talking about here is known vulnerabilities. So if it's a known vulnerability, there's two things to consider. One, why didn't the manufacturer of that product know about that or remediate for that? And maybe they did. And two, if I know about it, an attacker knows about it. So if we know that most of our devices that are in market or in production have lurking known vulnerabilities, we've dropped that threshold of making it difficult for an attacker much lower. Now, earlier I said most vulnerabilities, we're surprised how easily they can be compromised. This is one of the reasons why. And it's not just patient monitors. There's patient monitors, infusion pumps, drug libraries, any number of different devices that make up the hospital infrastructure. The other thing to take into account, and that's important, is just like when we go to a doctor, if I go to a physician and I say I need a checkup, is that the last checkup I ever do? Absolutely not. Shouldn't be. But in many cases, when we implement technology in healthcare infrastructure, the last time it's looked at is when we go, or looked at in depth, is when we actually implement it. Now, there may be some processes to apply updates. Typically, those are going to be tied to, does that device have a maintenance contract with it? If it doesn't, is it internal IT infrastructure? What about all the software that is written internally by a hospital system? How do we monitor that? How do we check that? How do we keep going through that process and evaluating the health of that system or that software application? So you have to develop a plan. The plan starts with procurement. And when we talk about procurement, there's a couple of things that we are going to tend to focus on. And I am way ahead of schedule, so just so you know, everybody's going to get a little extended lunch, but I am going to be happy to answer as many questions as we want. But just want to throw that out there. So those of you who are reading email, you can do it in a little bit. But cybersecurity testing standards. We need to understand the environment, and we need to understand the security researcher. And I've given you a little bit of idea of what the researcher looks like and what some of the things that they focus on. But there are a number of tools that they're going to use. They're going to use software composition analysis. Well, that's a really fancy way of saying I'm going to take that software and I'm going to tear it apart to figure out what makes it work. What are the different pieces and parts that make up that software? And if I see something like OpenSSL 0.9.6, I'm going to go check that vulnerability database that tells me what are the known vulnerabilities for that. Okay, now I have a starting point. I can start digging in a little bit deeper and figuring out how that device works. And once I've figured out how it works, now I have something to leverage that device. Malformed input testing, another fancy way of saying fuzz testing. And everybody's like, fuzz testing, I don't know what that is. Basically, if I walk up to somebody and I say hello, I expect for them to reach their hand out, shake my hand, and say hello back, or how are you doing? But if I walk up to somebody and I say hello and I put my hand out and they slap me, that's a malformed input. I don't know how to react to that. I don't know what to do to it. So, it's when we look at medical devices and applications, a lot of the times we're focusing on, or the developers are focusing on, how do I get this product to market? How am I going to complete this so I can hit my timeline? What are the decisions I have to make as I'm developing this product? And I may not have other sources to go to as I'm making this decision. So is it really the best decision? It's hard to say. Those types of scenarios lead to what we call defects. And those defects eventually could gestate into a vulnerability. So those are the types of situations we want to start avoiding and addressing. How do we do that? Procurement language. I'm not going to dig into behavioral analysis or non-known malware analysis. Most organizations have implemented some type of security measure to address that. Behavioral analysis is probably going to be the most interesting in the near future. And for those of you who don't know behavioral analysis, there's a number of different methods, but what I like to focus on is network behavioral analysis. If I watch a network over time, I'm going to start to see patterns. I'm going to see these patterns over and over and over again, and I know those are normal. But when I see some type of network pattern that is abnormal, that doesn't fit the pattern, maybe that's something I need to take a look at. Problem is, this can create a lot of false positives, but every once in a while there's a gold gem in there that I can pluck out, and I may have found something that is of interest. Malware analysis. Most of the manufacturers that are out there, their solutions, we call this endpoint security as well. But when we talk about malware analysis, this is anything from somebody handing me a USB drive that has some software in there that's going to compromise my system, to somebody being really fun and writing a CD that says payroll on it, and they throw it on the floor in the middle of the administrative area and walk away and wait for somebody to pick it up and put it in their computer. And when they open that CD, they load their computer up with some malware. Most malware systems are going to detect those, but the reality is malware is pretty, it can be pretty interesting these days. But that's a very well addressed space. So back to the supply chain. Oops, I keep forgetting I have two different slides to move through here. I apologize. So this was the slide I was just talking about. But when I talk about supply chain management, all these issues that we've talked about, we want to eliminate that risk transfer that's happening to the healthcare provider. And I know there's manufacturers in the room and they're going, oh, wait a minute, I don't know if I like that. The same applies for you. As a manufacturer, you are buying third-party components. You're taking software from numerous different sources. How do we transfer that risk back to those originating sources? And if we do that, we end up creating a product or a solution that's much more robust than its individual components. So there's a lot of work that's actually been done with this already. When we look at supply chain management and the information related to supply chain, there's a lot of industry guidance out there. There's the UL 2900 guidance documents, IEC 62443, ISO, and many of the NIST SP 800 documents that are out there. But ultimately, what are we looking for? We want to raise the bar as to what level or quality of product you're bringing into your environment. And by doing that, we've also raised the bar for the attacker. They are going to have to work much harder and much more diligently to find vulnerabilities if we can eliminate all this low-hanging fruit. Now, I'm not going to go into the individual components. For those of you who are interested, I would be happy to collect business cards or emails and send you this information. These are documents that were freely distributed, and they are also not an end-all document. They're a framework to work from in developing supply chain management relative to your organization. But there's a couple of things I do want to highlight. The first one is when we look at these devices and these components that are out there, we're actually building a software bill of materials. When I go to pick up something from the grocery store, I have information that tells me exactly what I'm ingesting. What am I going to be eating? What are the components? What is the percentages? Everything related to that product. Maybe not everything, but a good chunk of information related to that product. Software bill of materials tells us the exact same thing. Now I know if I have OpenSSL. In this particular example, those of you who are a little bit more on the tech side, you'll notice I have 1, 2, 3, 4 versions of OpenSSL in one particular product. Why is that? That tells me a couple of different things. The software development lifecycle for that organization probably isn't very robust and should be evaluated. It also tells me the versions that are there are much older than the current version. So why are they not evaluating that? Some of that's going to be driven by, from a medical manufacturing standpoint, when I start designing a device, that could have been 2 or 3 or 4 years ago before it ever made it to market. And that's okay. But what is the remediation process that you're going to go through as a consumer of this device to get up-to-date data and information and software packages related to that? And having maintenance isn't the answer. Because when maintenance expires, then what do you do? Now, the FDA has started to address this issue. There are a number of discussions, guidance that are out there trying to build a better picture of what this looks like. But there's nothing solid that says each manufacturer must do X, Y, and Z, not as prescriptive as we would like. So the point to this slide is, if we look at from a eating perspective, a product that we're ingesting, why would we expect any less than software, or from software? Why is it any different? We need to raise the bar as far as what is being brought into our environments. What is the quality of that product that's being brought into our environment? And how do we address this as an industry without requiring additional regulation? That is, we've all seen, we've kind of had some of these discussions earlier. Yes, we tend to see more progress from a regulatory standpoint when there is regulation. But when we see large providers as Mayo, Kaiser, and a couple of other ones that are out there pushing back on the manufacturers, we start to see that we can drive this ourselves and create a better environment, have more robust and higher quality products. Rinse and repeat. Why do I say rinse and repeat? I touched on this earlier. When I get a product in, that it should not be the last time I do an extensive evaluation of that product. Now, unfortunately, this puts a burden on IT if we use traditional methods. But if we look at software technologies that are out there that are more cutting edge, a lot of this work can be automated. And if it is automated, we can get much more dynamic reports that tell us this infusion pump model XYZ has this version of software, and this version of software has just popped with a CVE vulnerability level 10. So for those of you who aren't techs in the room, what does that mean? CVE is a common vulnerability enumeration, and there's a 0 or 1 to 10 rating scale, 10 being the highest. And 10 is the impact, potential impact for this particular vulnerability. So if I have an infusion pump that's rated a level 10, I need to take action on that now. I need to do something immediately. Who remembers OpenSSL? I'm sorry, Heartbleed.
Yeah.
Okay, that wasn't very far back, but really already it's kind of old. Heartbleed's 2.5 years old, coming up on 2 years old. OpenSSL was rated a 5 from a CVE standpoint. If it was rated a 5, why was it such a big deal? Well, that 5 rating is related to exposure of data. And if I can listen at the right points, I can gather a large amount of data. But more importantly, how many people in here knew every device in their infrastructure that was susceptible to Heartbleed? Day one. Nobody. There just was not the tool or the understanding or need to have that type of information available to you. Now it's critical. When we see these 0 days that are popping out there that can quickly propagate, especially in organizations that have standardized across multiple locations and facilities, this is a real issue. You have to be much more proactive and much more realistic in how you address these issues. So these types of tools help address that. So if we're going through and we're doing the rinse and repeat, we have a very good idea of what the risk factors are within our infrastructure and our facility. Now, there is additional help. I do want to point out, for those of you who are not aware, UL recently released their CAP program. their cybersecurity assurance program. And what their CAT program focuses on is the very same things that we've talked about today, or I've talked about today. How do we raise the bar from a security perspective and ensure that we have devices that are much more robust than what we're used to seeing? The CAT program has an extensive description of what type of testing should be performed for a device. And that's part of the UL 2900 specifications, and they are available from UL. But what's more important to that is, as an organization, now you can start to ask your manufacturers and your providers, is this device, does it meet UL 2900 standards? If it doesn't, when will it? So this is definitely something to take into account as one of those measures that will help address your security needs and your security focuses. And lastly, I'm just going to touch on a couple of things. This one's always my controversial slide. I don't know about that, but at a minimum, for goodness sake, raise the bar. Even if there's just a little bit of analysis, and from a healthcare perspective, we've had HIPAA high tech, so from a healthcare perspective, we've done that. Now we just need to raise that bar a little bit further. But my challenge is, do it without impacting IT. IT is overloaded. We all know that. There's a lot of high-level initiatives and products that are being thrown at them. But really, there are a lot of things that can be done if we just ask the questions. Even just a little bit of vulnerability analysis can go a long way. So when we take a look at software composition analysis and we understand what the products are and the constituent components of those products in our infrastructure, we use that in an automated fashion. That gives IT a great head start on addressing the potential issues that may pop up. Stop drinking your own Kool-Aid. As a healthcare provider or a manufacturer of healthcare components, you do what you do very, very well. But do you do security as good as a security researcher or a security analyst? Probably not. That's what they focus on. Bring them in. We all hear about hackers, black hats. They all have their particular reasons why they do their things. Sometimes it's notoriety, sometimes it's money, sometimes it's just for fun. But from a researcher's perspective and an analyst perspective, they're out there looking and trying to mitigate these issues before they impact you. So support them. They're there to help you. Billy Rios, like I said, he's a great-looking guy. Have him out. Have him visit. He's also really, really nice. And then verify and validate. I've already touched on this a couple of times in my previous slide, but we really want to go through that verification and validation process. What I like to term it is trust but verify. I like you as a manufacturer. I really like your product, but I want to verify what you're telling me. There's nothing wrong with that. So with that, that's the end of my formal presentation. Can I answer any questions?